Ladies and gentlemen, good morning and welcome to this session titled Cardiology 3 Diagnosis and Prognosis. Thank you for being here. I hope you all had your coffee and are prepared to stay awake. My name is Prem Soman. I'm from the University of Pittsburgh, and it's my pleasure and privilege to co-chair this session with Dr. Ken Lee, who you all know, who's a cardiologist and nuclear medicine physician from Melbourne. The first talk for this session will be by Professor William Van Gaal, who is the Chief of Cardiology and also a nuclear medicine physician at the Northern Melbourne. And his talk is titled MPI for Diagnosis and Prognosis, Clinical Indications and Appropriate Use in 2018.
My conflicts of interest are that I'm an interventional cardiologist as well as a nuclear cardiologist, and I also perform CT coronary angiography, but I don't perform stress echocardiography or stress CMR. I've been charged with talking about appropriate use in myocardial perfusion imaging, which of course necessitates talking about the appropriate use criteria. The appropriate use criteria were developed to reflect real-world clinical practice by coming up with scenarios for which are suited to stress imaging. This is, of course, both a strength and a weakness because the number of potential clinical scenarios far outweigh the number of scenarios that are described in the guidelines, which in turn far outweigh the available evidence for testing in these specific groups. So I will outline my talk along the outline of appropriate use criteria, but we'll focus on the discussion of symptomatic patients and asymptomatic patients and how we should assess risk. And we'll have a look at some specific conditions which I think highlight the issues with appropriate use criteria. I won't talk about sequential testing or post-revasc and pre-op evaluation really in the interests of time, because I'd like to discuss how the appropriate use criteria perform overall when we look at our practice and how they might be used. And we've published a paper this month in Heart Lung Circ, which I'll present to you. The appropriate use criteria don't discuss unstable patients, and nor will I today. So what is appropriate use? An appropriate investigation is one which the expected incremental information exceeds the expected negative consequences, and they are the risks of the procedure, exposure to ionizing radiation, exposure to contrast, and perhaps most importantly, the downstream effects of poor test performance, that is, the effects of false positives and false negatives. It's important to note, however, that the appropriate use criteria are designed to improve patient care, but they are not intended to ignore ambiguity and nuance, which is intrinsic to clinical decision making, and as such, they should not be considered substitutes for sound clinical judgment. Why have we got appropriate use criteria? Well, they were developed in 2005 after an explosion in the costs of reimbursement for cardiac imaging. And in fact, in the United States from 2000 to 2006, reimbursement for cardiac imaging alone went from 1.6 to 5.1 billion US dollars. That is huge, and it's no wonder we have appropriateness criteria. Although there were some issues and confusion with wording, and they were revised in 2009, but were still modality specific. Each scenario was labelled as appropriate, uncertain, or inappropriate, but this was felt to be too fairly categorical and confusing for referrers. And the most recent iteration which we have is the 2013 now multimodality appropriate use criteria with 80 clinical scenarios which are described as appropriate, maybe appropriate, or rarely appropriate. More recently, the methodology for developing these guidelines has been updated, and this has recently been published, and I suspect this is in preparation for a new iteration of the appropriate use criteria. Since appropriate use criteria have been developed, there has been a small but significant decrease in the expenditure for cardiac imaging. So in the most recent iteration of the multimodality guidelines, the goal was to determine which testing modalities may be reasonable, but not which is the best test. So they didn't compare tests directly. The writing committee developed 80 clinical scenarios, and using a Delphi process, which is an iterative process to achieve consensus, the writing committee ranked each scenario from a scale of 1 to 9, with 7 to 9 being appropriate and 1 to 3 being rarely appropriate. There were many assumptions made. The general assumptions were that all patients could undergo all tests and tests were not compared. Contraindications were not considered, for example, renal dysfunction. The risks, the benefits, radiation safety, cost and value were not considered to systematically downgrade or upgrade one test over another. So these are considerations that should be applied at the bedside when referring patients for these investigations. 80 clinical scenarios were divided into 4 groups: patients with signs or symptoms, or patients at risk of coronary heart disease. The second group were patients with prior test results or follow-up of revasc, and then pre-op evaluation and patients being referred for exercise programs. So let's have a look at the first group. So this is the sort of table that the appropriate use criteria publish, and you'll notice a few things. One is that all the modalities are side by side, but given this talk's on myocardial perfusion imaging, I won't be referring to those. A is for appropriate, M is for maybe appropriate, R is for rarely appropriate, and importantly, appropriate is not necessarily a class 1 indication to test a patient. So it's not an indication, it's just that it is an appropriate investigation to do in that group. So not surprisingly, for symptomatic patients at intermediate pre-test probability and high pre-test probability, perfusion scintigraphy is appropriate, but it's the group with a low pre-test probability that is interesting and perhaps the most controversial, although it is specified that these are patients with uninterpretable ECGs or unable to exercise. So how do we measure pre-test probability? Well, you'll all be familiar with the Diamond and Forrester evaluation, which is basically based on symptoms. Typical symptoms being retrosternal chest pain or discomfort that is precipitated by exertion or emotion and that is relieved with rest or nitrates. And if you have all of those features, you have typical angina, and if you have none of them, you have non-anginal chest pain. The European guidelines have actually modified this and have actually found that the original Diamond and Forrester stratification probably overestimates risks. You can see in the European guidelines they include patients who are older, yet very few women, for example, are classified as high risk despite the inclusion of patients over the age of 70. The appropriate use criteria are in direct contraindication to the European and the American guidelines. The European guidelines define low risk as less than 15% risk of coronary artery disease, which is essentially women less than 50 with atypical symptoms or all young men, and they don't recommend testing in this group. The American guidelines go into a little bit more detail and suggest that if you're unable to exercise, pharmacologic stress echo is appropriate. But interestingly, myocardial perfusion imaging is a class 3 indication and is actually not recommended, although both are based on expert consensus alone with no underlying evidence. So I think in the next iteration we might see a downgrading of the classification of appropriate for low-risk patients, although it's important to say that uninterpretable ECG often is equivalent to left bundle branch block, and testing for patients with left bundle branch block is a separate issue which I'll talk about in a moment. What about asymptomatic patients? For asymptomatic patients, the guidelines recommend that those at intermediate risk with an uninterpretable ECG or those at high global risk are suitable, may be appropriate to undergo myocardial perfusion imaging. But how do we assess global coronary disease risk? The Framingham-based studies, the Framingham-based models are recommended, particularly those that predict heart events, that is death and myocardial infarction. But these risk scores don't perform well in women or young men. The Framingham-based models for heart events, that is death and MI, don't include important clinical information such as a family history of premature coronary artery disease, which can be used to influence judgment, and interestingly don't include diabetes. Diabetes has traditionally been considered a coronary artery disease equivalent, but last year the 2017 American Diabetes Association said that in asymptomatic patients, routine screening for coronary disease is not recommended as it does not improve outcomes as long as atherosclerotic cardiovascular risk factors are treated. And this is based on 2 randomised controlled trials. One is the DIAD trial of myocardial perfusion imaging published in 2009, and the Factor 64 trial, which relied upon CT coronary angiography. Both studies had very low yields of severe coronary artery disease and no survival for benefit of screening. However, both of these studies enrolled patients at the lower end of the risk spectrum. They were younger patients with diabetes of shorter duration, importantly less than 10 years. Their diabetes was generally well controlled. They had a normal ECG, preserved renal function, and a very low incidence of concomitant vascular disease. From the Kaiser Permanente group in the US, they looked at 1.5 million diabetic subjects and followed them up for over 10 million person years, and did find that if you do have diabetes for longer than 10 years, then your risk of future events is indeed equivalent to patients with established coronary artery disease. And from other groups, this is the Mayo group, nearly 1,500 asymptomatic patients undergoing perfusion imaging. And compared to these 2 studies, these patients had a longer duration of diabetes, they had renal impairment, and 1/3 of them had peripheral vascular disease. 58% had a positive myocardial perfusion scan, and 18% had a high-risk scan based on their sum stress scores. Those patients tended to be older and have ECG abnormalities and peripheral vascular disease. And importantly, those patients with a high-risk score had a much lower survival than their normal counterparts. This group also gave us this data, which is not randomised, but showed that those patients with a high-risk score who underwent revascularisation had a better survival compared to patients who were treated medically. Other groups have had similar findings. So the American Diabetes Association do acknowledge this evidence and provide the following recommendations: that stress imaging or screening for coronary disease could be used in the presence of atypical cardiac symptoms or signs or symptoms associated with vascular disease, such as peripheral vascular disease, or in patients with ECG abnormalities. This is a patient we studied last month at the Northern. This is a young female asymptomatic patient with diabetes and stage 4 chronic kidney disease, and you can see she has a reversible perfusion defect involving the anterolateral wall with a small residual perfusion defect at rest, but nevertheless a positive study. And I went on to perform her angiogram, which shows significant 3-vessel disease with bifurcation disease in the LAD, a long segment of mild to moderate plaque in the proximal LAD. She has significant disease in the AV circumflex and the large obtuse marginal, with significant disease in the distal right coronary artery. And she's been, this asymptomatic patient's been referred for coronary artery bypass grafting. I love this quote: "It's hard to call a positive test inappropriate. I call that clinical judgment." And of course, if we throw stress imaging at all comers in a specific population, we're not going to get we're not going to see positive outcomes. But if we select patients for high risk using global risk scores and then applying judgment, we can select patients who are at a higher likelihood of having coronary disease and who are more likely, therefore, to benefit from medical therapy and revascularisation. So I think that maybe is an appropriate indication for asymptomatic selected patients using clinical judgment. There are some other cardiovascular indications which I thought were interesting. Newly diagnosed diastolic heart failure is given an appropriate classification, and of course this stems from data in systolic heart failure, where excluding patients with coronary disease or not is of course mandatory because the treatment implications are very different. But in fact, looking at imaging or stress imaging for HFpEF, heart failure with preserved ejection fraction, there's no data in that specific population, and really the indication for appropriate use comes from the prevalence of coronary disease, which is still very high in the HFpEF population, around about 50% of patients. And importantly, the presence of coronary disease in this population imparts a higher mortality. So the guidelines give this a class 2 recommendation, basically based on expert consensus, really. What about new onset atrial fibrillation? This scores a maybe appropriate. If we look at testing in asymptomatic atrial fibrillation, This is not many patients because most patients with AF do have symptoms. But if we're looking at truly asymptomatic patients with AF, if we apply stress imaging to all comers, we get a very low yield of positive studies with a low revascularization rate. Factors that are associated with mortality in this group are high global risk, the inability to exercise, and poor LV function, but not ischemia. This study was a little bit limited because non-fatal MI was not assessed. And it does conflict with other studies which show a much higher rate of abnormal tests in an asymptomatic AF population, which probably reflects the fact that these were single-centre studies and these were representing differences in referral patterns. The guidelines are a little bit more useful in atrial fibrillation, with the European guidelines stating that patients with symptoms or signs of ischemia should undergo coronary angiography or stress testing as appropriate. And the American guidelines also specify that testing is useful to exclude ischemia before treating patients essentially with flecainide, which is not an uncommon indication. Syncope is an interesting group of patients. There is no reference to stress imaging in the syncope guidelines, either the European or the American College of Guidelines. Exercise testing, of course, is useful for exercise-induced syncope. And if we look at all comers with syncope, even in those at high risk, the yield is fairly low, and syncope is given an appropriate criteria, mainly because it's specified patients with high global risk, which we've just discussed, which are suitable to have testing in their own right in selected patients. Left bundle branch block. Well, left bundle branch block is bad. In the Framingham study, 48% of individuals went on to develop symptomatic coronary heart disease, and this has been shown by other groups. Vasodilator stress has been the preferred methodology, perhaps up until recently, to investigate these problems because of the artefacts produced by stress exercise testing. Other groups have advocated the use of CT coronary angiography in detecting these patients because it's not subject to the artefact that other modalities may be. I perform both of these investigations. We're lucky enough at our institute to have two high-end machines. We have a CZT camera and we have the Siemens Somatom Flash. When the registrar comes to me and says, "Bill, what test should we perform for this patient with left bundle branch block to exclude ischemia?" These are the sort of clinical judgments or nuances that go on in my head when we're discussing these patients. Is the patient obese? Do they have atrial fibrillation? Can we control their rate? Do they have renal impairment? These are the sort of things that sway me more towards myocardial perfusion imaging than CT coronary angiography. I prefer myocardial perfusion imaging in the older patient as well, because I don't want to sift through the calcified coronaries trying to decide what is 50 to 69% and what's greater than 70%. And of course, we could take this one step further. What is the question in left bundle branch block? Does the patient have CAD? Well, then CT coronary angiography, of course, is a suitable test, but it's not the full question. Does the patient have CAD that is causing ischemia or has caused scar or a reduction in LV function? Is LV dilatation the substrate? And of course, if these are the questions, which I think they are, perfusion imaging is more suitable, but I acknowledge that we would get a lot of this information from the echo the patient has presumably already had, and that CT is beginning to address some of these questions. I'm going to skip ahead in the interest of time to discuss our paper that came out this month in Heart, Lung and Circ, which looks at utilising the appropriate use criteria in clinical practice and how it might be useful. We looked at 1,000 consecutive patients retrospectively who'd had a myocardial perfusion scan at our hospital and found that roughly 83% of studies were deemed appropriate by the criteria. A small proportion of patients were performed in the maybe appropriate criteria, and just under 8% had a really appropriate scan. 1.8% we had difficulty classifying because they were unstable patients, essentially, who aren't covered by the appropriate use criteria. You can see that in our practice, the majority of testing is performed for symptoms, and that a large proportion of patients in our study had non-anginal chest pain, although this is problematic retrospectively because often on the request form or the workup sheet we will write chest pain, but it's not specified as retrosternal or exertional or relieved with nitrates, for example. So if that information wasn't available, we had to assume that the patient had non-anginal chest pain, but this would have artificially increased that group. We performed relatively little testing for other indications in comparison. There are two interesting findings from our study. One is that in patients with a rarely appropriate scan, and this was 77 patients out of the 1,000, not a single patient had a positive study. Now, we were quite harsh with our definition of positive. To have a positive study, you had to have a reversible perfusion defect, or you had to have a fixed perfusion defect with no known history of prior infarction, and you had to have one other marker of infarction, such as Q waves on the ECG or a regional wall motion abnormality. So our definition of abnormal was quite strict. But if we look at the rarely appropriate group, not a single patient had a positive scan. If we look at the appropriate group, this was by far the largest group. And the maybe appropriate group, which probably represents a larger potential cohort of patients, was relatively small. And the positive rate was the same for both groups of patients, which says to me that in clinical practice, we're quite good at applying clinical judgment to those maybe appropriate patients in order to achieve the same positivity rate in scans. One of the difficulties we have with our rarely appropriate scan is that they are mostly referred by our non-cardiology colleagues or non-specialist colleagues. The majority of these referrals were from primary care physicians. We compared our study to other studies, and it's probably mostly aligned with the study by Dookie, which showed... Thanks, this is the last slide, and then I'll summarise, which showed a similar detection rate to the Dookie study. Of course, it does depend on your definition, but we were quite pleased to see that we had a very low rate of inappropriate scans compared to other studies. I'll summarise by saying that the appropriate use criteria do not substitute for clinical judgment. An appropriate test does not equal an indication for that test. That's important. The nuance of specific clinical scenarios make appropriate use criteria problematic for controlling testing. They've only had a modest effect on the rate of imaging over the past decade, but they do provide a useful audit tool for practices to evaluate their practice as a whole, rather than an application to individual tests at the patient bedside. Thank you.
If there's one or two compelling questions, we can ask those to Dr. Van Gaal now. Otherwise, we'll move along in the interest of time. Okay, we'll take further questions at the end then. Thank you. We'll move on. I'm pleased to welcome Professor João Vitola from Brazil, who will talk to us about one of the most important trials in clinical cardiology for this decade, amid some recent controversy, I should say, as well. So this is the ischemia trial. It's actually spelt with an A in Australia, but it should be without the A in the American presentation. Is this the final word? Thank you, Joe.
Thank you. Thank you very much. Good morning, everyone. And I thank you so much for the kind invitation to come back to Australia. It's really an honor to speak at this meeting, and great pleasure to be among very good friends. So my task is to discuss with you in the next few minutes about the ischemia trial and whether or not this is the final word. I would like to start by doing some brainstorm with you, going through some facts, and also raising some questions before we get to the data that we have so far on the ischemia trial. First fact, the presence of CAD correlates with increased mortality. Higher the extent of CAD, higher the mortality. CAD patients are an heterogeneous group of patients. And this has been shown through different techniques. Can be shown by quantitation of calcium, by number of vessels, non-invasively, invasively, several different ways. Patients with coronary disease can have no ischemia, and sometimes very advanced extensive coronary disease, or a very high ischemic burden, such as this patient on the right. The presence of ischemia correlates with increased mortality. We know this for many years from the nuclear literature. Higher the ischemic burden, higher the mortality. Ischemic patients are an heterogeneous group of patients. The question is, can we reduce mortality by reducing ischemia through revascularization? And if so, which would be the ischemic patient that would benefit from revascularization? Would this be the patient, perhaps? Some questions were raised by the COURAGE study that was published in the New England Journal in 2007. And basically, the same group of people that worked on the COURAGE trial is now working on the ischemia trial. Would COURAGE have shown a benefit from PCI if the target population had been higher risk, moderate or severe ischemia? If clinical trials in the optimal medical therapy era show no clear death or MI benefit from an initial strategy of revascularization, are CAF revascularization necessary prior to a trial of optimal medical therapy? We are all familiar with this data from our colleague Rory Hakamovich, which perhaps is the most frequently shown slide in every single cardiology meeting. But even Rory acknowledged that this is pretty weak data. This is an observational study of approximately 10,000 patients that shows a benefit from revascularization once you have larger areas of ischemia above 12% or so. But this is retrospective. This is registry data. This is not randomized data. What is the best initial management strategy for patients with moderate or severe ischemia? And this is what the ischemia trial is trying to solve. So the way to answer that question would be a randomized trial, such as the ischemia trial, randomizing either to invasive or conservative arm. And this was the initial idea of this NIH-sponsored trial, which it costed approximately $100 million. The initial idea was to include 8,000 patients, stable patients with at least moderate ischemia, who would first undergo CCTA for two reasons, either to exclude a left main lesion or to identify ischemic patients that potentially had no obstructive disease, which wouldn't make sense to randomize to an invasive arm. And the idea was an average of 3 years of follow-up with the primary endpoint, and pay attention to this, of a composite of cardiovascular death or myocardial infarction. One of the problems is that along the way, the trial changed a little bit. First, as actually some of us had initially suspected, this would be a very difficult trial to run. So 8,000 patients were not possible, and the sample was adjusted to 5,000 patients. Secondly, the number of events that occurred along the trial had been initially overestimated. Therefore, the primary endpoint, and pay attention to this, was changed to a composite of cardiovascular death, MI, unstable angina, heart failure, resuscitated cardiac arrest, with key secondary endpoints being cardiovascular death or MI. And for this reason, ischemia trial is facing very significant criticisms, many different parts of the world. As some understanding this change in endpoints as moving the goalposts during the game. And there have been recent papers written with criticisms about this change. But the investigators, what they say is, this had already been predicted in 2012. 2012 had already been specified potential changes from 2 to 5 component of primary endpoints. And because the trial had less than expected rate of events, in June of 2017, so last year, the panel recommended to elevate to these 5 primary endpoints. What are the numbers that we have so far on the ischemia trial? 8,700 patients were enrolled. 10% had insufficient ischemia. Interestingly, and pay attention to this, 21% of the patients, despite evidence of significant ischemia, were found to have no obstructive disease. And probably we'll find out once the final results are published that this was a combination. Some artifacts, some microvascular disease without significant epicardial disease. So some very interesting subgroup of patients. Approximately 9% had left main disease, etc., which end up with 5,179 randomized patients in 317 sites in 37 different countries. These were the top 10 sites in the world, randomizing patients. Approximately 1,000 patients were randomized at these 10 sites. Randomization was closed in January, and the last visit projected is for June of next year. What can we expect from the population that was randomized to the ischemia trial? And I'll concentrate not on this CKD, which is chronic kidney disease part of the trial, but I'll concentrate on this 5,000 patients of the main trial. So age of the population being studied, 64 years old, 23% are female, BMI of 29, 39% are diabetics, which I believe is a very important aspect. Very high prevalence of hypertension, prior myocardial infarction in 19%, prior PCI in 20%, prior bypass surgery in 4%. Heart failure, none, 61%. New York Heart Association Class 1, 19%. Class 2, 19%. Ejection fraction, 60%. 90% of the patients did have history of angina. And what do we expect? We expect some presentations next year at the American Heart Meeting and in 2020 at the ACC. So is the ischemia trial going to be the final word? One thing we can say is that this trial randomized a lot of patients, much more than the Courage and the Body 2D, more than double the number of patients. And some interesting data we already know. This is core lab data. 20% of the patients came from echo, 43% from nuclear, 3% from MR, 34% from the ECG. Total of over 8,000 patients. I don't have, and I of course could not show you the numbers for the final randomized patients. What do we know from the nuclear data? Insufficient ischemia in approximately 25%, moderate ischemia, 55%, 20% with severe ischemia. 90% of cases were read in the core lab as being of good or excellent image quality. From echo, 18% sufficient ischemia, 28% moderate ischemia, 53% severe, 49% read by the echo core lab as good or excellent quality. MR, 13% insufficient ischemia, 29% moderate ischemia, 57% severe ischemia, 64% read as good or excellent image quality. ECG, 22% were deemed to have insufficient ischemia, 59% severe ischemia, 20%, only 20% of cases were of good quality. So, how heterogeneous can a group of ischemic patients be? Do all ischemic patients would respond similarly to revascularization? First questions we have to raise. Was ischemia identified by which technique? Was this adequately assessed and quantified? Which territory was involved? The LAD, the non-LAD, one vessel, multi-vessel, proximal LAD involved? Is this a 10% in the LAD? Is this the same as a 10% on the PDA? What's the severity of the ischemia? Different patterns in different territory. Mixed ischemia, scar in one territory, ischemia in the other territory, pure scar in another territory. What's the extent of ischemia above 10%? Is it 15, 20, 50%? Different perfusion patterns. LV function. 10 to 15% of ischemia with an EF of 35%. Is this the same as in a patient with an EF of 70%? What's the functional capacity of that patient? 10% ischemia with 3 METs. Is this the same as with 13 METs? What about patient-related? Is the 10% ischemia in a 40-year-old the same as in an 80-year-old? What about females versus male? So as you can see, we have many questions that will not be answered by the ischemia trial. So we will wait anxiously for the publication in 2020. It will certainly add some information to the literature and will help us progress one more step to answer some of these very difficult questions. There will still be many unsolved issues for sure. And in my opinion, we are only scratching the surface on this very difficult equation. Thank you very much for your attention.
Any compelling questions?
Thanks, Joao. I didn't actually realise how many of the actual group were actually just simple exercise ECG without any imaging.
Yeah.
How do they judge severe ischemia on exercise ECG?
This, you know, I had, because I'm one of the investigators in this trial, I argued tremendously when that decision was made to include stress testing without imaging and consider the ECG, the stress ECG, as an image. They thought the argument was good, but if the patient had typical angina with at least a 2 millimeter ST depression and was found to have at least a 70% obstructive lesion, that was going to be considered to be enrolled in the trial with a cutoff, a cap of maximum of 20%. So those 30-something% that I show you were all the patients that were considered, not the final randomized patients. So we expect to have approximately 1,000 patients that had only stress ECG. But with this situation, there is an obstructive lesion identified, The patient has classic typical angina and at least a 2 millimeter ST depression. I wouldn't have included those patients, but this was one of the decisions taken along the trial because of the difficulty of randomizing and such an important change of paradigm to randomize a severe ischemic patient to conservative measurements.
Thanks, Charles. That was very good. I was just interested that in the original recruitment of 8,000 odd patients, I think it was about 20% were excluded. Now, that's not so much, it's what the exclusion was interesting. Was that because nuclear or stress echo really has that relatively low sensitivity? Do you think that's why so many were excluded? That's quite a lot of exclusion, about 20%.
The patients that would be excluded and not considered for the trial would be patients with low ejection fraction, for example, below 35%, if I'm not mistaken. Mm-hmm. And patients, once you've done the CT, that would show no significant lesion. Is that the 20% that you're talking about?
Yeah.
This is a very interesting subgroup of patients that, of course, there will be a study of those patients. And apparently, there are more women in that group of 20% of patients with no epicardial disease but significant ischemia.
They're still ischemic. That's the problem, isn't it?
Yeah. So we'll see. We'll see how many of those are real ischemia. We'll see the prognosis of these patients, because this will, in fact, will be the most interesting.
Can you tell us anything about crossover from the medical therapy group to the revas group at this stage?
Yeah, very high. It was higher than in the Courage trial, which was around 35%, if I'm not mistaken. So it was very high. It's very difficult. This was a very difficult trial to run from the start. You know, it's very difficult once the cardiologists know the patient has significant ischemia. It's what we know today, based on our literature, that's a high-risk ischemia. It's very difficult to prevent that patient from undergoing a revascularization, even though there's equipoise. We understand the equipoise part. We understand. But internationally, these are patients that most of the times just go to revascularization. So we'll see. It will be interesting.
Just lastly, there's a huge percentage difference in the poor quality studies between the different modalities. Do you have any further data as to the reasons for those poor echoes and poor stress tests?
Certainly this will be a major discussion, because these are different core labs. Of course, nuclear is in one university, echo is in another university. These are very experienced readers reading these scans. So I think this will be one of the very important conclusions of this, and there will be a specific publication about that.
Okay, thank you. Okay, it's a great pleasure to welcome the current president of the American Society of Nuclear Cardiology to speak to us today for the Read with an Expert session, and he certainly is. Patient-centered imaging, where does MPI fit in? Professor Soman from the US.
Thank you, Ken. Good morning, ladies and gentlemen. Thank you for the invitation. I feel very privileged to be here. I bring you greetings from the American Society of Nuclear Cardiology. Before I begin, I see many young people in the audience, and I want to remind you all that ASNC offers free membership to all trainees, whether you're training in nuclear medicine or cardiology. So I would encourage you all to make avail of that opportunity, and you get a free copy of the journal every issue when you do that. Now, when faced with a patient with stable chest pain, as clinicians, we have to answer some important questions. Is this angina? How much of the myocardium is in jeopardy? And will coronary revascularization have added benefit over medical therapy alone? So as I see a patient, these are the preeminent questions in my mind. So I want to emphasize that the question is not just about diagnosis, but we weave into that management plan a prognostic construct, because it is on this that treatment choices are dependent on. So let's take a real-life patient, a 66-year-old lady with a history of prior myocardial infarction, bypass surgery, presenting with exertional angina. Now, she's a bit obese, chronic kidney disease resulting from diabetes and hypertension, and she had a pacemaker for sinus node dysfunction. So if you look at our armamentarium of tests that we have at our disposal to test, with a BMI of 32, although this is not universally true, perhaps echo is not the best first option here. She has chronic kidney disease, and direct invasive angiography or coronary CT angiography is probably not the first thing you would do. And she has a pacemaker for sinus node dysfunction, so MRI still is not widely utilized in this population. So stress myocardial perfusion imaging was the only non-invasive test applicable in this patient. And this constellation of clinical characteristics is not unusual. And in a substantial proportion of patients like this, MPI is the only test that you can apply. And this is important because when we talk about performance characteristics, we generally talk about efficacy. We talk about sensitivity and specificity, and these are tested under very controlled conditions. We take patients who are able to have a test, and then we compare the performance characteristics against a gold standard. But another characteristic of testing is effectiveness. And this is a measure of how the test works in real life. If you were to sit in your outpatient clinic and randomly assign patients to different testing modality, how many patients will end up getting that test? And we know that there are many contraindications to CT and MR, such as renal disease, contrast allergy, atrial fibrillation, devices, claustrophobia, inability to hold the breath, the ability to exercise, and in these patients we generally prefer to do exercise testing. And as you can see, SPECT can be performed in all of these patients. It has very high effectiveness. And this comes across very nicely in a multitude of clinical trials. For example, if you look at studies that have compared CT angiography and acute chest pain SPECT in the ED evaluation of chest pain, and take two studies, CT STAT and ERASE. In CT STAT, 6,640 patients were screened to enroll 740 patients. And a large number of these screened patients were not included because they had contraindications to CT, as opposed to a SPECT-based study where 85% of the patients screened were actually enrolled in the trial. Again, supporting the concept of very high effectiveness. So if I throw a question out to the audience and say, what is the contraindication to a myocardial perfusion scan? There is none. Anyone can have the test, and it can be combined with exercise, vasodilator stress, and inotropic stress. So very, very high effectiveness if you look at the place of MPI in our armamentarium of testing. So this patient went on the treadmill, did about 7 minutes on the Bruce protocol, achieved a good target heart rate. Angina was reproduced. Now, as a clinician, this is very, very valuable information for me, to put a patient on the treadmill and reproduce symptomatology, especially if it is associated with objective signs of ischemia, which in this case it was. There were ECG changes suggestive of ischemia. We then go on to the myocardial perfusion scan, and at the bottom is the polar map showing the resting study, and you get a quantitative evaluation of resting perfusion defect. The total perfusion defect here was 11% of the myocardium. We then look at the stress study. There's clearly reversible perfusion abnormality. This is again quantifiable. And now you have a quantitative measure of the percentage of LV myocardium that's ischemic. It's about 13%. And this is the amount of myocardium that is in jeopardy in this particular patient. Very valuable quantitative information. Now, when you look at the functional data, you get a quantitative and highly reproducible measure of ejection fraction. You see the slight paradoxical, postoperative paradoxical septal motion there. And of course, you can identify individual areas of regional wall motion abnormality that correspond to the areas of myocardial infarction. Now, this particular patient was scanned on a CZT crystal camera. We report doses in our final report, and this is directly from the report. You can see that the total effective dose was just 6.9 millisieverts for a very high-quality study. And this, again, is a copy of our final assessment. We talk about functional capacity. We say that the patient had reproducible typical angina on the treadmill. The hemodynamic response was normal. We talk about the perfusion abnormalities, the vascular territories, and then we say that approximately 13% of the left ventricular myocardium is at risk and LV function is normal. And despite the observational nature of this data, and Joao was right, this is the most commonly shown data in any cardiology conference, but this is what we have. And to me, the most compelling reason to use this data is that it's physiologically tenable. If you have large areas of the myocardium that are ischemic, should that particular stenosis convert, become unstable, and produce an MI, the patient will lose a large area of the myocardium, and it's very reasonable to assume that that will result in a bad outcome. So that, to me, is the most compelling reason to believe this data. Now, if $100 million doesn't get us a good and convincing clinical trial, I don't know what will. And so for the predictable future, I think we are going to be left with observational data. And today, I think our approach to patients are prevaricated on the degree of myocardial ischemia, and I think that will remain for the foreseeable future. So what additive information did the SPECT give us? It gave us functional capacity. It gave us a quantitative measure of infarct and ischemia. It gave us a quantitative measure of LV function, and it gave us some guidance. It gave us a modality-specific guidance on treatment allocation. Somewhere along the 10 to 15% mark, more ischemia than that is likely to result in improved outcomes after coronary revascularization. So now if you look at the tests for stable CAD that we have at our disposal, you can classify them broadly into functional and anatomical tests, and they're listed here. So what is the major difference between using a functional test versus an anatomical test? And I want to show you two important differences. On the right-hand side, there is an angiogram, an invasive coronary angiogram, showing a very significant obstructive lesion. Now, if this were a CT angiogram, you will get some more anatomical information, very important anatomical information on outward remodeling, spotty calcification, so on and so forth. But the most important information is on luminal obstruction. On the left side is a perfusion scan showing ischemia. This also tells you there's likely to be obstructive disease, but it also gives you information about vasoreactivity, endothelial dysfunction, and microvascular dysfunction. So what the perfusion scan is telling you is what is happening at the myocardial level, and that is a composite not only of the anatomical dysfunction that is happening, but also the functional status of the vessel. And we know from many studies that vascular vasomotor dysfunction alone can produce perfusion abnormalities. And I think we saw that in the preliminary data from ischemia that Joao showed. Now, we also see that reflected in clinical practice. Here is a patient who in 1997 was put on very intensive medical therapy because he had inoperable three-vessel CAD. And the perfusion scan done in 2003 shows a substantial and striking improvement in myocardial ischemia. Now, we know from studies such as Asteroid that you do get small reductions in plaque. There is some degree of plaque reduction with intensive medical therapy, but an 80% stenosis is not going to become a 40% stenosis. So a lot of our medical therapy improves vasomotor function and decreases ischemia. So it is really important to get that functional information in addition to the anatomical information. The second important information is the extent of ischemia. I'm going to talk a little bit about functional anatomical testing with FFR. So here is an angiogram showing you the circumflex coronary artery, and let's say this patient has an 80% stenosis with an FFR of 0.7, and let's say this is the extent of myocardial ischemia, right? Now let's take the same defect, let's take the same stenosis, 80% stenosis, FFR of 70, and now you have this much ischemia, right? So the anatomical information with FFR was identical in both cases, but the location of the lesion and the extent of ischemia is really important because, again, that's what our treatment is dependent on. So this additional information that you get from functional testing, I think, is really important. So in the final few slides, I think we are at a very, very interesting point in our understanding of coronary artery disease and how to test for stable coronary artery disease. And so I'm going to give you a little bit of a construct on what the data show us, and this is sort of how we practice at the University of Pittsburgh, and this is where functional testing, and in this case, myocardial perfusion imaging fits in. So if you have patients with intermediate to high probability of coronary artery disease, and perhaps patients with known CAD, here I think the determination of extent of ischemia is really important, and perhaps the first approach should be a functional test. It's also important to remember that while CTA has a very high negative predictive value, the positive predictive value is not as high as its negative predictive value, and that's where heart flow and fractional flow reserve assessment has come in. And our recent meta-analysis shows that it's early days, and this is just one bit of data, but there may be problems with FFR in the intermediate range, exactly where we need it. So in this population of patients, high pretest probability, patients with known CAD, I think a functional test has advantages over an anatomical test. Now, in patients with low pretest probability, I think it's very likely that an abnormal functional test is more likely to be false positive. You take a young woman with atypical chest pain, myocardial perfusion scan, an anterior defect is most likely to be attenuation artifact than a true defect. And in this particular group of patients, anatomical testing with high negative predictive value is very powerful. If you don't have coronary artery disease, you don't have coronary artery disease. Now, we're also beginning to understand the unique characteristics of coronary artery disease in women. And at this point of time, I think there is value in doing a functional test in women, particularly with the idea of identifying ischemia without coronary artery disease or microvascular disease. And finally, should we combine calcium scoring with MPI? Now, the construct here, and we know this, that there is an additional benefit of detecting subclinical atherosclerosis. But I will point out to you that that additional benefit is small. For example, in the PROMISE study, in patients who did not have obstructive coronary artery disease but did have subclinical atherosclerosis, the additional risk of an adverse event was about 2% over 2 years, so about 1% per year. So a definite added risk, but a small risk. And what we don't know is whether we can identify and treat these patients simply based on the risk profile. So if you have somebody with diabetes mellitus, hypertension, and dyslipidemia, and you treat them intensively anyways, is there any added value of knowing whether they have subclinical atherosclerosis? Thank you very much.